At the end of maybe a tiring day, it's good to have something completely different. I think the audience is old enough that you have all seen some parts of Monty Python's Flying Circus. Maybe you remember that at the end of Monty Python, you always had a part in that BBC. You always had a part in which there was coming something completely different, and that's what we are going to do right now. We are going to talk about a topic which is more related to public health than to medicine. Maybe the distinction between medicine and public health is a little bit artificial, but what we are going to do is we are going to talk about fine dust and other airborne pollution. And we are going to talk about the consequences for you as a doctor or as a scientist, as an, let's say, as a public health worker, what to do with it. For instance, if parents of children who are attending school, which is based quite close to a highway, and they are worried because their parents or because their children are coughing, what to do then? What kind of advice can you give? Now, these kind of questions are very important nowadays. Maybe not all of you know the situation here in Maastricht, but Maastricht is an interesting example. So we have a beautiful city here in the south of the Netherlands, but there is a highway running through Maastricht. Maybe you've seen it, it's quite close to here. And there is a lot of worry of the population here. What is this highway causing to our children, but also to us? Is it causing air pollution? Is it threatening our health? Is it threatening our lungs or our heart diseases? Now, that is an important question. So what to do about this issue? We have 4 panel members, and they are world expert in their area, and they are going to discuss this issue. We have some statements. You see already statement number 1. But what we are first going to do now is we are going to listen to them. They will introduce themselves to you, and also to state some of the background in this area. Can I start with you, Jos?
Certainly, Mr. Chairman. Thank you. Ladies and gentlemen, my name is Jos Rooijackers. I am chest physician of the Netherlands Expertise Center for Respiratory Disorders caused by occupational and possibly also by environmental exposures. Together with occupational physicians and occupational hygienists, we bring together expertise in the field of exposure assessments, exposure measures, diagnostics, and also prevention measures in workers with occupational related diseases. We do that in collaboration with the University of Utrecht, together with the Institute of Risk Assessment Sciences in Utrecht, and with the University Medical Center.
Okay, thank you very much, Jos. Ben, can you continue?
My name is Ben Nemery. I'm from the University of Leuven, not very far from here, although in another country, in Belgium. By background, I'm an occupational doctor and I have a PhD in toxicology, but I have the privilege of working with chest physicians in the university hospital, and I have a clinic that is specifically dedicated to see patients with occupational or environmental lung disease. And I'm also involved in research, including epidemiologic research in air pollution.
Okay, thank you very much. Lee? Okay.
I've met many of you already. My name is Lee Newman. I'm a chest physician by training. 5 years ago, after having practiced for 20 years at National Jewish in Denver, Colorado, 5 years ago moved into the School of Public Health, where I'm a professor of environmental and occupational health. And there, I continue to work in the area of occupational and environmental lung disease. And I direct a center which trains professionals in industrial hygiene, measuring exposures in your environment, ergonomics, radiation-related health and occupational health psychology, and we integrate that into the teams that investigate occupational lung problems and other occupational problems.
Thank you, Lee. Aalt?
Yeah, my name is Aalt Bast. I'm originally trained as a chemist some time ago, and then I worked for a long time in the field of pharmacology, molecular pharmacology, and then moved 15 years ago to Maastricht to become head of toxicology. Well, and a toxicologist, as most toxicologists, they want to know why a compound is toxic. That is one. And we do that from a molecular perspective, basically. And the second point is, of course, to try to prevent the toxic responses of compounds. And that can be drugs, that can be food-derived compounds, and it can be particles.
Okay. Thank you so much. Now, I think the panel is really very good, and they can answer probably all questions we have. That's, but it is not a matter that we are going to ask questions, but we should really have an interactive discussion. So I would really like to invite you to take part in this discussion. So that would be good if it is as interactive as possible. Use the mic and identify yourself, and then we can have a good discussion. So I already explained to you that we have 6 statements, and we can start with the first statement, but we don't have to finish them all. It is more important to discuss with each other. Because what is a very good question to start with is it really a problem? Or is it just imaginary, this problem? Is it just a thought that fine dust and most other airborne pollution is really so dramatically as is stated here? So what you can see here, fine dust and most other airborne pollution is invisible and therefore doesn't attract much attention of the general public. However, with almost 20,000 subjects dying yearly in the Netherlands, that is the figures from the RIVM, 10 years earlier than expected due to this exposure, it is a silent killer. It is what smoking was 50 years ago. So that is the statement. Can I ask you, Ben, what is your reaction? Is it really true? Is it so dangerous that we can really say it's a silent killer?
Yeah, I would agree it's a silent killer, but then so is tobacco smoke.
Mm-hmm.
And in fact, tobacco smoke is fine dust.
Mm-hmm.
It's do-it-yourself air pollution in a concentrated fashion.
Mm-hmm. That's a nice expression.
and that's why we've discovered that it was so harmful.
Yeah.
And it is also one of the reasons why we should not stop our fight against smoking.
Mm-hmm.
Active smoking, of course, passive smoking. The issue of urban air pollution or ambient air pollution, I think, is attracting more attention now in our countries than in the past. But it's a little bit paradoxical because the air pollution now, although it's talked a lot about, is actually less important than it used to be. I mean, less the levels.
The concentrations
are now less than they were 20, 30, 40 years ago.
Mm-hmm.
But there's much more attention to it. And I think it's right that there is attention from the public, from the media, from the doctors. Mm-hmm. Because it is indeed a silent killer. The priority that it's given by decision makers depends, I think, from the input that they receive from scientists, and also from pressure by the electorate.
But you are such a scientist. I mean, you have co-authored the Lancet paper not long ago published, and that was about the impact of different causes on cardiovascular diseases. So can you tell a little bit more, what was the relative impact of fine dust?
So the paper that you're referring to was the result of a systematic review of the various triggers of myocardial infarction. And we all know that in these triggers there is heavy exercise, there's emotions, and also exposure to air pollution. Mm-hmm. But the common comment that we received, being in this field, was, the risks that you show are minimal. Mm-hmm. You have odds ratios or risk ratios or 1.005, which is ridiculous. Yeah. Which is true, and we heard from Ron that population averages or group averages, you should not be translated immediately to the individual situation, which I agree. But the other thing is that you should also look at what part of the population is exposed, and when we then multiply a small risk by a large exposed population, then we come to sizable public health effects. And the conclusion of that systematic review was that exposure to air pollution is a risk factor of the same order of magnitude as the ones that are well established, well accepted by the medical community, and hence it's not trivial. Mm-hmm. That was
were you surprised by this finding? On a general population level?
No.
Or did you expect it?
Well, my hunch and my co-workers was that it is indeed important, but we had to demonstrate it, and we were pleased that we were able to show that the risk was substantial. Yeah. And we were able to put figures on it, and the figures show that it is, of the triggers of myocardial infarction, it is substantial. It's about the same as heavy exercise, drinking a lot of coffee, and so on. So it's not. It's not to be trivialized.
But the difference with drinking a lot of coffee or smoking is that you can actually change your habit. Sometimes it's difficult when you're addicted to coffee or when you're addicted to nicotine. But still you can change. And here it is quite difficult to change the area you're living in. So what kind of consequences should this have?
The consequences for the decision makers and for public health policy is that if air pollution is indeed important, then you should, not by individual changes, but by public health measures or by structural policies, make sure that this factor is decreased.
Okay.
But I don't want to monopolize the debate.
No. But that's very good. Let's first listen to a reaction.
Yeah, I'm a little bit confused. I'm not aware of your article, so I apologize for that.
Never mind.
I don't think the mic is doing it. Is it?
Yes, but
it is.
I wanted to say I didn't read it on quiet as possible. Now, one of the questions I'm having, I'm confused between fine particles and air pollution. There are multiple things in air pollution, and I would think of things like ozone and other things that we have focused on in the last 30 years. And if you're saying that one thing is a problem in pollution, there's not much you can do perhaps about getting rid of all the air in an industrial setting, but certainly efforts have been made to get rid of certain pollutants. So the statement starts with fine dust, and you're talking about data about air pollution. So I guess my question is, what specific things were you able to identify, and how is that epidemiology done? How were you able to get fine dust and air pollution and such?
Yeah.
Or was that?
The interesting thing about fine dust is that it seems to be harmful almost regardless of the origin of that fine dust. So fine dust is indeed very complex, and fine dust here is not the same as fine dust on the east coast or west coast of the United States. But even so, it is one of the most consistent damaging agents in air pollution research. And we don't know what exactly in fine dust is the most harmful. Could be metals, free radical generating agents, but it doesn't seem to matter that much where it comes from, providing it's mainly from combustion sources. Did you agree with that, Aalt?
What is your opinion?
Yeah, I think it is indeed a good question, and there is even skepticism among toxicologists when you talk about the toxicity of these particles. I'm a member of the National Health Board, and then we discuss these things and to come up with advices for the general government, for the government. And then even among colleagues, you see there is skepticism, and that has probably to do with the fact that these particles do not have a one-hit, one-target effect. We as toxicologists are used to talk about compounds that have a certain defined effect. And with fine dust, the particles do not have one defined effect. And exactly what you mean, when you have air pollution, it is not one thing at the same time. Even for particles, it is not one thing. If it would be one thing, one target, one effect, then you could manage it and you could bring it back to molecular level, and then you can explain it. And for fine dust, that is more difficult.
First, Professor Kostebal, and then I give the word to Lee. Ulrich.
So I want to know the expert's opinion whether this statement is true, that this is the same as smoking was 50 years ago. I see they shake their heads, so then it's clear. Because what you said was a risk factor for triggering myocardial infarction with a very low relative risk. A person who is a lifelong smoker, or let's say 20 years, how high is his risk that he gets coronary heart disease and dies? And that's a basic pathogenesis why he is at risk for getting a heart disease. And these patients, if they then are additionally exposed, then they get this. Probably a person without coronary heart disease, he would be safe even with these ultrafine particles. Is that correct or not?
It was on purpose that we stated in the way as we did.
Just to know whether
Lee,
somebody who is a non-smoker has not coronary heart disease, is he also damaged and has some risk by dying earlier due to these fine dust particles?
Lee, please.
I think from a public health perspective, it's important to put this in context with tobacco. First of all, it's not what tobacco was 50 years ago, and it's probably not what tobacco is today. If approximately 25% of people living in the Netherlands smoke, which I gather is about the figure.
28 at the moment.
28%.
It's much worse than the US, that's for sure.
Yeah, well, I take little solace in that because we're still at 20% or approximately that.
Okay.
Then it's probably not even what tobacco is today as far as a risk. Now, that being said, I just want to emphasize and build on something that Ben said, which is that it means something different if you are within a susceptible part of the population. Not everyone handles these particles the same way. Some of us are more vulnerable. And we may be susceptible both by our geography, where we live in relation to pollution sources, as well as because of our underlying risk factors such as our age, young and old, whether we have underlying diseases such as lung diseases or cardiovascular diseases. So I think that that's still that adds up to a large number of people. But we do have to, rather than just taking broad statements of averages, think about the impact on select populations. And that's certainly been an approach that we've taken. I'll give you a very brief example. We've been conducting a study in my state in the United States, in Colorado. We do a great deal. We have industries that are drilling into the earth to obtain natural gas deposits. And in the process of doing that, they put the drilling very close to where people are living. And these are rural communities until the drills come in. And the question has been raised, well, what do we know about the impact on these communities? And the approach that we've had to take in assessing risk is to look at how close they are to the pollution source that's been introduced, and who are the people, what are the risks that we as individuals living in that community have, and target our intervention.
But the question obviously is it possible really to make a good guess and to estimate, for instance, figures like these? I mean, they are obviously quite different in the US, but 20,000 subjects are dying earlier Can you estimate it? Is it really possible to do this? Is it really? What do you think, Jos? Is it possible to make such an estimate? You're working together with RIVM and IRAS.
I think what's used here are models in which you try to come to close to an estimation of what could go going on. At the other side, of course, in these models there are many uncertainties, and you have to live with that. But at the other side, if you have more and more studies pointing to the same direction, I think you have to accept that there will be any effect.
And looking to the
but
literature,
the magnitude is the problem.
And looking to the literature, you know the literature quite well. You think these estimates are accurate?
As far as I can see now, yes, I think that you have to accept these numbers, yes.
Please.
Hello, my name is Peter Dieck. I'm coming from the Medical University of Gdańsk in Poland, and my question is also putting in consideration about the lecture before from Dubois, that it seems that a lot of these issues are very selected individual patients who actually suffer from this. And would it be worth doing first genetical analysis before putting like on laws or rules for industries and guidelines for that?
Who would like to react? Yes, Ben.
I think there is an inverse relation between the magnitude of the risk and the individual, the possibility of doing something to the individual. I don't think you could genetically identify people who will be more susceptible to air pollution and then do something about it. You could do that for very, very specific risks in very selected industries, and then you might have ethical problems in there. But I don't think your approach would be sensible from a public health point of view.
I mean,
okay.
If I just,
I agree
that the ethical issue is probably very, very difficult and very sensible. But to find the cause and the relation, it seems like an just rational approach, see who is susceptible to that.
You mean to understand the mechanism?
To understand the mechanism, from molecular point of view, and then try to see how can we change it. Because as far as I can see it, and also from political point of view, there are analysis, ethical, public health. They do statistics and they say, okay, we prohibit it. But there are also people who do not suffer from certain diseases and how to attack this problem.
Okay.
The thing is with the statement that you made here, that 20,000 subjects die yearly in the Netherlands. Nobody knows out of the 100,000 who die every year. Who are these 20,000? Actually, it's all the 100,000, they all die a little bit from air pollution, rather than a statement like that.
You can never attribute it to one factor. That's the problem.
Certainly not
where you're talking about.
Certainly not if it is a very diffuse
exactly.
factor.
Lee?
Yeah, just to comment on Peter's question, which is very provocative. And I've been through this for many years because I've studied a particular case example of beryllium. First of all, I think it makes a bold assumption about genetics, that we are so good at that we understand how genetics interacts with exposure. I would say to you, we don't. Secondly, it assumes that fine particles and other air pollutants obey a different dose-response curve because of genetic susceptibility. And to my knowledge, that has not been established. So now I'll give you the case example briefly of beryllium, where we know that there's a very strong genetic risk factor. It's a particular HLA, HLA-DP, B1, GLU69, that if you have that particular allelic substitution and you are exposed to beryllium, you're at a very high risk of developing beryllium disease. Unfortunately, that allele is present in about 45% of us. So if you take that example, you might have an industry that says, well, we want to know which half of you have that particular version of the gene, and we don't want to hire you. You're out, and we'll just work with you.
Make it simple.
It would make it simple, and you might say from a public health standpoint that would be the best thing to do. There's only one problem. First of all, even that gene, which is a very strong association and well proven, that gene does not explain all of the disease that occurs. Mm-hmm. And so the idea that we work from is, let's start by controlling the exposure level for everyone, and the most susceptible will benefit, but everyone else will benefit too.
One way to influence airborne pollution is to have a better legislation. So let's look to the second statement. If we can have the second statement. Present EU legislation, as well as the Dutch one concerning PM and NOx, is not based anymore on our present scientific knowledge on the harm for children, elderly, and patients with cardiovascular or pulmonary disease. Jos, could you react on it? You know the Dutch legislation, you know the EU legislation. What do you think? Is it correct? Are we running behind?
I really think so, that there are several goals of, at one side, the administration or the government, on the other side, patient organizations or healthcare professional organizations who have totally other aims to protect civilians or their patients. On the other side, we have our economic activity. Exactly, so we have financial incentives who are very, very strong. So I think there are some good examples that the government is systematically trying to manipulate or to recalculate the risks by looking at different portions of the particular matter. For example, the sea sand, trying to get different levels, and doing that way to give the way for building along the highways, or to increase the number of highways we have. So the interests of groups in society are different, and that gives some tension on the system. So I think yes, it's correct here. The problem for doctors dealing with patients is when a patient is asking you, okay, I have asthma or COPD, I am a risk group, do I have to move on? Do I have to move to a better area, to a forest area or in the north? Or
well, what do you advise to your patients?
Now that's the problem of how is it possible for me to translate the things we know from public health, from the epidemiologic results in the open population. How can I translate it towards the individual? It's a little bit the same question as was put forward just ago. It's very difficult. It's very hard to take it with you and to come to a conclusion for one patient and give him advice based on epidemiological studies.
When parents of coughing children are coming to you and asking advice concerning their children, and they have children on school based quite close to a highway. You have many of them in Utrecht. So what do you advise them? I mean, that's really a social problem.
That's really a social problem. On the other side, I have no real data on which I can base a good advice. Yeah. So you get a little bit of trial and error, but it's very subjective. So for me, it's still lacking, and I think a little bit too early. And I really hope in the future that if we could have other information, other markers for the patient, for example, genetic information, then I perhaps could come more close to a good advice.
Aalt, you're an active member of the Dutch Health Council, advising the Dutch minister in legislation, Dutch legislation, EU legislation. Do you think, is it adequate what we're doing at the moment or not?
Data is largely lacking. What Jos said is indeed a problem. Data is lacking, and that makes it difficult. For a long time, we regard association
Yeah.
And that is then accepted as causal relation, and that is not enough. That is really not enough. Association is not a causal relation. That is.
But how to prove it? I mean, when you have an environment, you can't take away your environment. It's not like a drug. It's not like smoking.
What government is always doing, that they take into account what we call the precautionary principle. If you are not sure, don't do it.
Yeah.
That is always what government is doing, and that is how that is what the voter also want from them.
Exactly, that's what they ask.
And that is at the same time, that is a problem. If you do that to a large extent, that is a problem, because then you get away the, let's say, innovation, you get away economics principles, you harm that, so that is a problem. You cannot do that to a too large extent, and that is a balance. It is not a clear answer to your question, but you cannot answer it completely.
No, I'm trying to get an answer from you. Lee, you wanted to answer?
Well, I think you've touched on something that is really at the heart of this. If we had all the money, then what we would do would be to minimize the risk for everyone as much as possible, right? But there's a trade-off that we make in society between environment and economic advance, right? That's at the heart of this. And so, in fact, what you're asking us to answer here, all of us, is what do we consider to be an acceptable excess risk? Is it 1 in 1,000 additional deaths, or children with asthma exacerbation, or pick whatever the endpoint is, heart attacks? Is it 1 in 10,000? Is it 1 in a million that we will accept? And with each of those comes a true financial cost to a society.
Yeah.
That's the trade-off. I'm not going to pretend to be able to comment on this particular question, but just to set it in that proper context. That's what we're talking about here. It's a trade-off between health and economics.
And do you have any clue how to answer this question?
Well, you know, we draw different conclusions on that depending upon who you talk to. Those of us who have treated sick people where we know that there's an attributable cause tend to be very aggressive to say do more to reduce their exposures.
Yeah, there is another remark from you.
Yeah, I'm sorry. I'm struck by the fact that you're taking an example of something that we would all accept because there is a model, which is beryllium. And you say, well, the intervention here would be get away from the beryllium. To another model, which is, let's get rid of the particulate mass and we'll get rid of nitric oxide. So we'll move to the country. Well, the country's got some other problems. And so it's not clear before you make this assumption, which seemed to me you'd have to actually know, and I think that's what your point is. You'd have to actually know what the intervention and whether that would help it. And it seems like you need to have that part of it. And we're not only economically, but actually what intervention would actually be effective.
Okay. Ben.
I think one of the problems when you talk about legislation is that there is no evidence that there is a threshold below which air pollution will not cause some harm. So there is a scientific problem there.
Yeah. It's just an artificial cutoff.
There is probably no real threshold in terms of PM. And to go back to what is it in PM, Joel Schwartz from Boston says that PM is like, what is it in PM that causes the problem? It's like an orchestra. What you have is the music, and it's not necessarily the strings or the drums or that give the good music, it's the whole. And by analogy, air pollution is a little bit like that. PM is like an orchestra, and it's all the components that are harmful that give the music. But so the problem is that there is no threshold to say that we will be perfectly safe.
But then still, if you're saying that, Ben, it is the most burning question. What is the most dangerous musician? So what?
It's probably the loud music rather than the individual component of the music. Is it if it's very loud?
Okay, but still, then maybe Aalt, well, you're doing a lot of research to let's say the content of fine dust and all the radicals. Should we look at radicals? And is it you had just a talk about radicals, and is it what we should focus on?
I can make it a little bit more complex, even if I may.
It is already so complex.
But you see what the problem is. We said there is no threshold also with regard to radicals. Not demonstrable, but There is also something, and that is in the let's say scientific community heavily debated nowadays, especially among toxicologists, the term hormesis. Perhaps you know, a little bit of toxicity might even be beneficial. That makes it even more complex. For radicals, that is the case. If you are exposed to a low level of radicals, that is not always bad. It can even be beneficial because all kinds of systems are triggered on. And it makes it even more difficult. So you cannot say you should go to zero. No, perhaps you need some damage.
One cigarette a day?
For example, yeah, there is not a real damage there, and that makes it difficult. Eh?
I don't hope that there are any media here
but
in the audience.
Let's say for
because then it's going wrong.
One more addition, because it can be too dangerous if we would say that. Let's say for stochastically, so damaging compounds, the compounds that act on DNA, for example, by coincidence, then every hit is one too much. That is the problem then. Eh? But for compounds which are acting in a more complex way and act on a homeostatic level, low levels of damage can be even beneficial. That makes it a little bit more complex.
If we're talking about legislation, we should advise governments, EU Parliament or US Parliament, we should advise them what to focus on. On what, I mean, PM is so broad. Lee, what should we do?
Well, I think in a sense you've led into your third statement.
Yeah, exactly.
And I think you have to be
Maybe
very
you can
careful.
Put on the third statement.
The third statement that more research is urgently needed. So I've never met a researcher who said, "We're done. We've done enough research." I haven't met one. If you are, then you don't need your research grants.
You can take another job.
Right, take another job. So we're always going to say that there's a need for more research. I'd like to, though, not be facetious, but to really make the statement that in this situation, we know enough for there to be policies put in place to protect people better. Mm-hmm. Yes, we need more research. We will do more research. We will learn more. That should not be a reason to sit back and say, oh, we'll just wait for the research.
And that's what you see often politicians doing.
Well, it's a fallback position to say, oh, we'll support more research as a way of saying,
it's an excuse.
Because that way we have an excuse not to act now.
And to act.
And we see that in all kinds of situations, not just in air pollution.
And not only in the Netherlands, I guess.
Right.
At least it is in the Netherlands. Yes, please.
Hi, I'm Renske. I'm from Nieuwegein. I have a question for Aalt Bast. I'm still thinking about the slides that you showed in the beginning of your presentation, where you showed mortality rates and like the difference in the 6 cities and also in time. And I was wondering, is it like all-cause mortality, or did you also see like in the 6 cities with the high pollution, maybe only pulmonary mortality or cardiovascular mortality?
These were data on all-cause mortality in the 6 city studies, as far as I know. Yeah, yeah.
The consensus among air pollution experts is that air pollution increases all-cause mortality, especially cardiopulmonary mortality. And that was a surprise initially. People couldn't believe that it was not only lung problems, but mainly cardiovascular problems. Yeah. And so a lot of research has been devoted to try and find plausibility to that, because it was hard to accept. But I think there are very few people who will now say that there is no effect of air pollution on cardiac or cardiovascular morbidity and mortality.
I think the proof there is overwhelming.
Yeah, because I was like, oh my God, Okay, thank you.
Okay. Marjolein is the boss here, and she says that we have almost to finish. But it would be a pity if we cannot touch upon the last statement. And can we go to the very last statement? That is about. I would like to ask a reaction of Jos, because that was a statement you would like to touch upon.
Yeah, that's right. Because we in the discussion before we talked about our environmental exposure, but in the meantime,
the last 6.
if we look at occupational exposure, in fact, you are at a totally different level, which is much, much more higher as exposure. And even then, looking at physicians working with their patients, you see that the attention towards occupational exposure is not so high. And are we, in fact, was that my question to the audience too? In fact, are we interested in the cause of a disease? If I have a construction worker who was working for 20 years as a concrete driller, who has COPD, Gold 2, are we going to looking further, or are we going just to treat his COPD? And if you and blame his smoking for his COPD, yeah. So you forget the situation behind this person, and the other problem is if you want to look for the cause of the disease, the question is, do you have the expertise of knowing the real risk of this patient? What is the risk of a construction worker, a concrete driller for 20 years? Has he really an increased risk of silicosis? Has he an increased risk for COPD? And if you make a high resolution CT scan, do you have the expertise of the interpretation of the CT scan? Do you rely on your radiologist who look to the CT scan? And in the treatment of these patients is another problem that we are busy in the individual healthcare. So we look at the interest of only the patient, but do we realize that behind the patient there are his colleagues who could be at risk too? So that your patient, in fact, is an index case, which could point to a problem at the workplace. And do we inform then the occupational physician? And do we, for example, report these patients in national registry programs by helping us to look at the magnitude of a problem at a workplace, or to identify new toxic agents for occupational diseases?
How is that at the moment done in the Netherlands, in
It's
other
poor.
countries, European, it's poor.
It's poor.
Yeah.
Because looking for the cause is difficult. Yeah. You need the expertise to do so. So we do it not so well. So for me is the problem. Let's start with the occupational exposure. And if we do that in a right way and we can learn from that, then perhaps we can move on to the environmental exposure.
How is that in the US, Lee? Is it? Are you working on such a, because I think it's crucial.
Yeah. Well, we have terrible problems in conducting occupational health surveillance.
Yeah.
In the U.S., the way it works, I'll give you an example. The Centers for Disease Control, our CDC, tells us as physicians, these are the reportable illnesses. And they ask for those reportable illnesses because there's a need to track them in society and to eradicate them. That's the presumption. So we track influenza, we track plague, many infectious diseases. On that long list, there is only one that comes close to touching on occupation. And no, it's not silicosis. It's not asbestosis. Thank you, Ben. This is perfect. It is not silicosis. It's not asbestosis. It's lead.
Okay.
Lead is the only one that is on that list that's actually reportable. There are state by state, some states that will have special reporting for cases of silicosis, with the intention of and cases of mesothelioma as an indicator of asbestos exposure. But it's by selected states. It's not uniform.
I see.
And so it's very haphazard. And the follow through to say, we have a case of mesothelioma that should lead us to look at the workplace. Does not follow through.
Still a lot to be improved. We have to come to a close almost. Is there any burning question or comment from the audience? You have your chance now.
Can I just make one?
A last.
Well, I don't mean to be last, because that's boring.
You will be.
Just addressing I think there are two issues here, and dealing with the second one first. I think all of us want to know what the causal agents are. But the problem is, with national registries comes paperwork.
Yeah.
And people at the end of their busy clinic,
they don't want to
do any more paperwork.
No.
So I've seen this with ILD that's not occupational. I've seen it in my own clinic where people are doing their own research and they still can't collect the data. So I think that's a resource issue.
So we should have electronic records.
I think we need something that makes it easy to capture enough to be able to study it later. And I think the second thing is that it's not just finding the cause for known occupational respiratory disorders. This meeting's focused on sarcoidosis. We want to try to figure out how to get triggers for diseases which appear to be idiopathic.
Yeah.
And so is an exposure 10 years ago, not to be repeated since, relevant to this granulomatous disease, if it was zirconium or beryllium?
Yeah.
So I think this is the crucial question, and I'd like to see you clever occupational guys help us out with the idiopathic disease and make it simpler to record it.
Okay, thanks.
Give us the resources.
Yeah. We have to finish. A last, let's say, burning comment from you.
My comment based on what Ron just said is that if you aren't asking people what they do for a living, then you are missing work-related illness.
Absolutely.
And it starts there, and it is so difficult to get that question asked. We're not training people well enough and reminding them enough that this is the starting point for that discussion. Does their current job or their past job have anything in it related to the current illness? And that's as clinicians where we have to start.
Okay. Now, I think we have to stop. Let's give a big applause for the speakers. Thank you so much. Hand over to you. Arlene, hand over to you. Do you want to anything? Okay. Thank you so much.